Hello, very good morning. We'll going to discuss about hysterectomy, mainly abdominal hysterectomy, and might discuss about what are the advantage of each route over each other, maybe a vaginal or laparoscopic or robotic. But I'll discuss more of abdominal hysterectomy. Yes, hysterectomy is an operation in which the uterus is removed. The cervix, ovaries, and a fallopian tubes might also be removed. It may be done abdominally or vaginally. Vaginal hysterectomy usually done for some cases of or majority of the vaginal hysterectomies are done because of the uterine prolapse. Nowadays there is something known as non-prolapse indications are being done vaginally, that is non-descent vaginal hysterectomy. Uterus there is no prolapse, but you like to take it out through vaginal route because of its advantages. Hysterectomy is the second most common surgery among the United States in women. 1 in 3 women in the US are done at the age of 60. Each year more than 6 lakhs are done. Over 90% are performed for benign conditions. More than 70% involved in surgical removal of ovaries. Abdominal hysterectomy was more common than vaginal hysterectomy. A proportion of vaginal hysterectomy is performed with laparoscopic assistance. That is being increased nowadays. That is called laparoscopic assisted vaginal hysterectomy. You assist the surgery with laparoscopically, release the first 2 clamps and complete the surgery through vaginal route. That is known as laparoscopic assisted vaginal hysterectomy. The indications are being fibroids, majority of the times corresponding to 30%. Endometriosis. In general, about the indications for hysterectomy, that is uterine prolapse, and oncological lesions like cancer uterus, cervix, and ovaries. The AUB, abnormal uterine bleeding after failed medical management and uncontrollable PPH. You have done all the possible measures, but you have failed to control it. That is the indication for doing a subtotal hysterectomy where the cervix is not removed, or it can also known as obstetric hysterectomy. Pelvic inflammatory disease, chronic pelvic adhesions, bilateral ovarian pathology, adenomyosis, pelvic congestion syndrome, intractable or recurrent dysmenorrhea, metrorrhagia, uterine anomalies, recurrent intrauterine polyps, uterine perforation failed to manage conservatively, mentally retarded patients with no hygiene control has to be certifiable. This is from the psychiatrist and the patient's party. Pregnancy, where there is a placenta increta, accreta. You have tried all the possible measures. Atonic uterus, uterine perforation, then ruptured uterus. Routes of hysterectomy: abdominal hysterectomy, vaginal hysterectomy, laparoscopic assisted vaginal hysterectomy, and laparoscopic hysterectomy, cesarean hysterectomy. Which route is the best? The results in the abdominal hysterectomy results in a greater mean blood loss, as the highest incidence of febrile morbidity and abdominal wound infection, obviously because it is an open surgery, longest hospitalization and slowest to recover. Whereas vaginal hysterectomy, it is the preferred route when technically possible, but here the skill is more when compared to abdominal hysterectomy, and the morbidity is less. Patient can be discharged quite early. Laparoscopic hysterectomy, it requires a team building or team training, and you need to have a good equipment. It requires initially more longest operating time. Once the learning curve is up, probably the time taken is same as of abdominal or vaginal, but shorter hospitalization with recovery is faster and greatest overall risk of complications. And there is a debate about its cost effectiveness, whether really it's going to be helpful for our Indian scenario, with the cost being is the questionable. And regarding to the choice of route, the factors suggesting that abdominal route may be the preferred one, insignificant to the uterine enlargement or fixity, inadequate transvaginal access, adnexal pathology and fixation, obliteration of pouch of Douglas. What are the types of hysterectomy? Subtotal hysterectomy, total hysterectomy, hysterectomy with BSO, or radical or Wertheim's hysterectomy, where it is done for malignancies, where there is a removal of adjacent lymph nodes apart from TAH BSO, that is total abdominal hysterectomy with bilateral salpingo-oophorectomy, and upper one third of the vagina being removed. What is partial hysterectomy? That is removal of 2/3 of the uterus. Total hysterectomy is removal of entire uterus and the cervix. Abdominal hysterectomy, coming to the patient preparedness, patient's at risk thromboembolism, pneumatic compression boots are applied, prophylactic antibiotic agent should be given prior or 30 minutes prior to the surgery. Incision can be a transverse or vertical. Generally we do with transverse. Need for exploration of the upper abdomen, then you need to do it as a midline. And that depends on the size of the uterus. Size is more than 24 weeks. There is no point in putting a transverse incision and struggling. Presence of prior incisions. If there are already incisions are there, you can expect some amount of additions. So it's better to take a midline and extend further and make the surgery at ease. And desired cosmetic results. Abdominal hysterectomy, the procedure, post-operative care, not necessary to leave a bladder catheter in place post-operatively for quite long time. IV fluids in the first 24 hours to ensure that the patient remains hydrated. Early feeding, regular diet can stimulate the bowel and decrease the length of hospitalization. Deep breathing to prevent atelectasis. Ambulation is encouraged. Intermittent compression boots, adequate control of post-operative pain. Maybe you can give it epidural analgesia. What are the advantages of subtotal hysterectomy? It is easier and quicker than total hysterectomy. There is a lesser danger of injuring the bladder, lesser danger of pelvic inflection. The cervix left to act as a support for vagina. The cervical discharge probably lubricates the vagina. Provides a better drainage for the operation area. That's a total hysterectomy advantage. If the cervix is lacerated or infected, the source of constant irritating discharge is being present. What are the intraoperative complications? The procedure proper, it's already you have seen in the clinical postings. So let me little more go into the procedure. Abdominal hysterectomy, once the abdomen is open, then the first clamp is applied over the round ligament, broad ligament. Then the second clamp is over the uterine artery, and the third clamp is over Macken rods. The sequence gets reversed when you do it vaginal. 1, 2, 3 clamps will become 3, 2, 1 in vaginal. So the intraoperative complications are ureteric injury, bladder injury, bowel injury, hemorrhage. So if you injure the adjacent structures and identify at the same time, that is good. Injuries can occur, but you have to identify on the table and correct it if you can, or otherwise call for an expert if available in and around. So hemorrhage, arterial bleeding from the uterine arteries or the ovarian vessels, blind clamping of the vessels, risk for ureteric injury. And the types of incisions which you have discussed: vertical incisions, fan and steel incisions. Then the abdominal hysterectomy, the uterus is removed through an incision in the woman's abdomen. It's the most invasive. Hospital stays for 5 to 6 days. Recovery time probably is 6 weeks. Possible retention of the cervix sometimes. required for endometriosis and large fibroids. The other complications are shock, hemorrhage, wound infection, intestinal complications, pulmonary complications like bronchitis, pneumonia, DVT. DVT prophylaxis has to be given postoperatively, that is deep vein thrombosis. Remote complications like vaginal wall, that's a later, not in the initial stage, maybe after some years. Vaginal wall prolapse, low backache, menopausal symptoms, sadness, irritability, depression, sexual dysfunction, and incisional hernias. Coming to the vaginal hysterectomy, the uterus is removed through vagina. It's the least invasive. Hospital stay is less, recovery time is less, cervix cannot be preserved. Indications for vaginal hysterectomy is mainly the prolapse, and nowadays is non-descent vaginal hysterectomy, and cancer surgeries also can be done vaginally, that is known as Shorter-Mitra operations. The prophylactic antibiotic agent should be given as like an abdominal hysterectomy. This post-operative management remains the same. Vaginal hysterectomy, if there is a cystocele correction, probably will keep a quite maybe another 24 hours catheter, or if there is a bladder injury, we like to keep it for at least 10 days after suitable repair. With the laparoscopic hysterectomy, the uterus is removed in sections through small incisions using a laparoscope, or you can take it out through vagina. Hospital stay is less. It is on par with vaginal hysterectomy. Recovery time is also less, but initially the longer duration requires a greater surgical expertise and the team and the good equipments. Urinary tract injuries, same like any other surgery. Fewer abdominal wall infections because you haven't opened. It's a minimal incision surgery, and bleeding is also less. And now it is a robotic hysterectomy. It's a three-dimensional image, greater articulation, eliminate hand tremors, increased accuracy and precision. But it is very expensive. The cost itself coming up to the instrument is 10 crores, and every recurring cost is around 1 to 2 lakhs per surgery, which is still a difficult scenario in the Indian setup. And the first successful surgery was done by the Da Vinci system in 1997. Three-dimensional view, operative field, adjustable magnification, which improved the vision. The risks and advantages: earlier onset of menopause in general, greater risk of cardiovascular disease, increased chance of osteoporosis and bone fractures, uncontrolled urination, and reduced libido and vaginal dryness. After hysterectomy, most women don't need pap smears except for those who had a previous CIN2 or CA cervix or CA uterus. Estrogen only HRT is an option except when BSO is performed for estrogen responsive cancer or severe endometriosis. Symptoms control in those patients can be a real problem. Current research suggests that ERT has many benefits and the fewer risks. What are the aims of the treatment is psychological preparation for the operation, to prepare the patient physically and mentally for the surgery, teach her the exercises that will be done post-operatively, and to improve the circulation, to improve respiration, and increase the strength of the abdominal muscles. Mainly the exercise training, deep breathing exercise, pre-operatively, rolling, coughing, huffing, ankle exercise, abdominal muscle exercise. Want to know the fitness prior surgery, and post-operatively you can manage accordingly. So to reduce the post-operative pain, we have TENS, that is trans electrical stimulation of the nerves, and laser to decrease the pain and enhance healing, and we have the better pharmacological drugs. and this you will learn it. Pre-operative care is like, what are the checklist has to be done in a pre-operative care? Consent, informed written consent in their own language if possible, and can be a video based, and cleaning of the area where the surgery is planned, even for a spinal part also, spinal area also, and bladder bowel has to be prepared, and check the drugs and the suture material one day prior itself. And post-operative care is, you need to monitor for, is there any bleed, that is hemorrhage. Hemorrhage is a more common after vaginal hysterectomy than after abdominal hysterectomy. You need to monitor vital signs. Catheter has to be removed once the amount of urine is avoided and there is no injury, and patient can be made ambulatory quite early. Look for any discharge or bleeding from the vagina. That can be a sign of infection. And mobilization, early mobilization is the most important, so that DVT can be prevented. And fluid intake has to be encouraged. And restrict the physical activity and the sexual intercourse at least for 4 to 6 weeks. So this has to be highlighted once you are sending her home. And some people might go for a depression because the uterus is, so that has to be, so any surgery, it is a stressful event that has to be tackled. And look for temperature, vaginal bleeding, is there any urinary incontinence following surgery or severe pain. So you need to check all this and need to provide an information about the HRT, and reinforce the need to obtain gynec examinations regularly even after hysterectomy, because vault malignancy or any other vaginal malignancy, any other lesions, it is not that hysterectomy done and no need to come for gynec OPD. That has to be stressed. She need to come for follow-up. Thank you.